Good afternoon and welcome to the Adventist Health Policy Association webinar on the Inpatient Prospective Payment System Fiscal Year 2020 Proposed Rule. We're going to get started here, and just as a reminder, if you can kindly mute your lines. If you have any questions throughout this program, you are welcome to share those questions via the chat box, and we will do our best to get back to you live. Otherwise, if you don't have access to the chat box, just mute your line now, and at the end, we'll have time for questions. This is coming to you from the Adventist Health Policy Association policy team. I'm Julie Zabak-Aldinger, and with me are our policy team members who will be leading out through this webinar. We are here for you not just for this webinar, but for a variety of your policy analysis needs, so just never hesitate to reach out if we can be of help to you on what's going on in the federal realm. So just as a quick refresher, what are we doing here today and what is IPPS? Well, the IPPS rule comes out annually, and this is where we have the reimbursement rate set for Medicare inpatient payments. This is also going to include multiple updates on Medicare quality programs. You see that on your screen. So we'll receive some really important updates on that from the team. As I said, this is an annual rule, so we always have the opportunity to comment on that, and the final rule will be released in August. So we're going to be working hard and hopefully with your input to provide our comments back to CMS by the June 24th deadline. And with that, I'm going to pass you along to the policy team who will lead us out on the rest of the webinar.
So on this slide, there's an overview of the issues that our team will be covering in today's presentation. We'll be talking about changes to inpatient payments, to the hospital wage index, changes to technology, add-on payments to disproportionate share hospitals, graduate medical education, as well as policy changes to CMS's quality program. In this year's rule, CMS is proposing to increase payments for inpatient services by 3.2% or $4.67 billion. There's an ACA productivity cut of 0.50%. Operating payments will increase by 3.5% or approximately $4.4 billion. Disproportionate share hospital payments will also see an increase of 2.6% or $216 million. And there will be a minor MACRA documentation and coding adjustment of 0.5%. Capital payment rates will also increase by 1.9% or $174 million. So now moving to the hospital wage index, which is one of the most significant proposals that were included in this year's rule. So every year, CMS adjusts hospital inpatient payments to account for the cost of labor in different states. The higher the wage index, the higher payments the hospital will receive for providing inpatient services. So states such as California or New York, where the cost of living is higher, will have a higher wage index and higher inpatient payments than states where the cost of living is lower, like Alabama or Minnesota. Those states generally have a lower wage index, and therefore the hospitals in those states receive lower inpatient payments. The data used to calculate the wage index actually comes from labor costs reported by hospitals in their cost reports, particularly sheet S3. And the data that is used to calculate it starts 4 years before the current fiscal year. And here you can see the calculation that is used for the hospital wage index. Now, in this year's rule, CMS is proposing to change the way it calculates the hospital wage index, because it argues that there are significant disparities between urban and rural hospitals, with rural hospitals always getting stuck with lower inpatient payments because the cost of living of their states where they reside is usually lower. This is an argument that is actually supported by the Office of Inspector General. In November of last year, the OIG released a report related to the hospital wage index that actually found several inaccuracies with the way hospital reported wage data to CMS. And this is what was stated in the report. From 2004 through 2017, the OIG conducted reviews of 41 hospitals' wage data, and in each case found material inaccuracies. In our 5 most recent reports, we estimated that a total of $140.5 million in overpayments to 272 hospitals resulted from the inaccurate wage data. Because of budget neutrality, those net overpayments resulted in approximately the same amount of underpayments to other hospitals nationwide. So basically, here the OIG is saying that because some hospitals were reporting their wage data inaccurately through the cost reports, that was leading to overpayments. Because the policy for the wage index is budget neutral, the overpayments to some hospitals resulted in underpayments to other hospitals nationwide. Now, in the rule, CMS is not proposing to address this issue with the inaccurate wage data, but instead, they're proposing to increase the wage index for certain rural hospitals by decreasing the wage index for certain urban hospitals. So to be exact, they're proposing to increase the wage index for hospitals whose wage index value is below the 25th percentile by 1/2 the difference between the hospital's wage index and the 25th percentile wage index. And then they will lower the wage index by 4.3% for hospitals whose wage index is above the 75th percentile. This policy would only be effective for fiscal year 2020 through 2024. At least that's what CMS is proposing for now. The rationale for only using this 4-year period is that CMS believes that applying this policy for 4 years will allow rural hospitals to increase their wages because, again, they will receive higher inpatient payments as a result of this policy. So that in 4 years, the wage index for that entire state would be higher and hospitals wouldn't constantly be stuck in that cycle in which they receive lower payments. And again, this policy is based on the assumption that the higher inpatient payments are going to lead to hospitals raising their wages in those states. CMS is proposing to apply a 5% cap for fiscal year 2020 on any decrease in a hospital's final wage index from the hospital's final wage index in fiscal year 2019. So any decrease cannot exceed 5%. And this is the impact that proposed policy would have to AHPA states if finalized, and this is based on data provided by the American Hospital Association. As you can see, AdventHealth would have a positive impact, but minor, of 0.4% or 520,000. Caring Health will not be impacted by this policy. Adventist Health would see one of the greatest hits of negative 0.59% or 3 million. Loma Linda University Medical Center will also see a big hit of negative 0.56% or 727,000. And we're happy to provide more details about this data at the individual hospitals if interested. CMS is also proposing to change the way they calculate the rural floor. The issue is that CMS has found that states can achieve higher inpatient payments for their hospitals by encouraging the reclassification of urban hospitals to rural. And this is how it works. So currently, the statute states that the wage index for urban hospitals cannot be lower than the one for rural hospitals. This policy was finalized many years ago because it assumes accurately that urban hospitals generally have higher labor costs than rural hospitals, and they wanted to make sure that inpatient payments reflected that. So what happens is that when an urban hospital reclassifies to a rural hospital, because urban hospitals generally have higher wages, that reclassification automatically causes the wage index of rural hospitals to increase for the entire state. Then when you apply the statute, any urban hospitals with a wage index value below the rural wage index will see an increase in their wage index, even though their wages never change. So basically, any urban hospital whose wage index value is below the rural floor will automatically see an increase in inpatient payments just because our urban hospital reclassified to rural, and that raised the rural floor. So here's an example that CMS used in the rule to illustrate this issue. Assume that the rural wage index for a state is 1.1. Any urban hospital with a wage index value below 1.1 would have its wage index value raised to 1.1, increasing Medicare payments. CMS is proposing to address this issue by excluding the wage data of reclassified rural hospitals from the rural floor calculation. That way, no matter if an urban hospital reclassifies to rural, that won't affect the wage index for urban hospitals across the state. Now moving on to add-on payments for technology. So these are additional payments that CMS provides beyond the standard diagnosis-related group amount to account for inpatient stays that involve costly technology. So this policy is an existing policy that was adopted to actually encourage hospitals to utilize new technology for Medicare beneficiaries, because they know that technology can be very expensive. CMS provides these additional payments to encourage the use of that technology. So the technology cost, actually, something happened. So what CMS is proposing to do is that they're proposing to increase the add-on payments from 50% to 65%. So if the cost of a technology is $10,000, that would result in an add-on payment of $6,500. Okay, that's what I was trying to find before. So the policy finalized would also increase payments for CAR-T therapy from $186,000 to $242,000 per case. CAR-T therapy is a therapy that has existed for only 2 years, and it is currently used to fight cancer. What the therapy does is that they extract the T cells from a person's body, and then they genetically engineer them and infuse them back to the patient so that those T cells can actually fight the cancer. CMS is not only proposing to increase the add-on payments for CAR-T therapy, but they also want comments on whether they should actually create a separate DRG for CAR-T therapy, and how should a new DRG be designed. For example, should be adjusted for geographic changes? What are some considerations that CMS should consider when developing a separate payment for CAR-T therapy? And if you have any thoughts regarding this issue, please feel free to email us or call us, and we'll be happy to compile your comments. Now moving to disproportionate share payments.
Okay, so just as a refresher, disproportionate share hospitals receive federal funding that helps them offset financial losses that they may incur because they serve a larger share of uninsured patients. So a hospital's DISH payment is a percentage add-on to its base DRG payment, and it's calculated very complicated, but based on some other factors, 3 years of worksheet S10 data. So CMS is proposing some updates and changes to the way that it would calculate DSH payments for fiscal year 2020. So first, CMS wants to distribute $8.5 billion in payments during fiscal year 2020, and that's a small increase compared to last year. It's going to result in roughly $216 million. For fiscal year 2020, CMS is also proposing to use a single year of uncompensated care data that would come from the worksheet S10. Currently, we use 3 years of data when calculating that. And so CMS wants to know what is the most appropriate data source that it can use to calculate these payments. Right now, CMS would use fiscal year 2015, but in the proposed rule, they ask if fiscal year 2017 data would be more appropriate and accurate in these calculations. So if you have any opinion or advice for CMS on whether or not they should change the year or whether or not 1 year of data would be sufficient, please reach out to us so that we can pass your comments along.
Now moving on to GME. As a brief reminder, graduate medical education is needed to train physicians after they graduate from medical school. Since Medicare pays more for GME, CMS tries to limit the amount they pay to these programs by limiting the number of residents that can be included in their medical education reimbursement. So CMS recently received feedback that there is a lack of residents rotating through critical access hospitals, making it more difficult to recruit and train doctors in these rural areas. Many critical access hospitals cannot support the cost of their own residency program, and other hospitals cannot count their residents as FTEs if they allow them to rotate through a critical access hospital under the current regulation. So in this IPPS rule, CMS is proposing to change the definition of a non-provider site to include critical access hospitals. This way, hospitals can let the residents rotate through these locations and still count them as FTEs as long as they are incurring all of the costs of the program. Additionally, there's an opportunity for hospitals to apply for residency slots that opened up due to the closure of Good Samaritan hospitals. The deadline for these applications is due July 22nd of this year. Now we're moving on to pain management for cancer patients. For PPS-exempt cancer hospitals, CMS is proposing to remove the same pain management questions that were modified then removed for other hospitals' HCAP surveys. In addition, CMS is seeking feedback on measures that could better assess pain management and addiction for cancer patients. What they're specifically looking for is on this slide. Again, if you have any input or comments on these items, please let us know. And now we'll talk about our quality programs. There are two types of quality programs with Medicare, mandatory and pay-for-performance. For the mandatory reporting programs, although hospitals are required to participate, payments are not affected by how a hospital performs in the quality measures. For the pay-for-performance programs, hospital payments can be reduced or, in the case of VBP, increased depending on how well the hospital performs. As a brief refresher, under the Hospital Inpatient Quality Reporting Program, CMS collects quality data to improve the quality, cost, and transparency by publicly displaying data to help consumers make more informed decisions about their health care. If hospitals do not report these measures, they will receive a 2% reduction. The measures are also generally used for the VBP program. There are 3 measures proposed to be included in this program. The first one is safe use of opioids, concurrent prescribing. In this measure, patients are excluded from the denominator if they have an active cancer diagnosis or an order for palliative care. The measure is also endorsed by the National Quality Forum, or the NQF. The NQF is a nonprofit organization that evaluates quality measures by helping foster consensus from stakeholders across the healthcare industry. AHPA supports the NQF measure evaluation process and usually asks CMS to use measures that are NQF endorsed if they're not already doing so. The second measure is a hospital harm measure, opioid-related adverse events. The NQF did not originally endorse this measure because there is concerns about the impact on chronic opioid users. In response, this measure was tested in more facilities, and CMS believes that this measure has been shown to be feasible to implement, reliable, and valid. This measure is waiting to be endorsed and is on the fall 2019 cycle measures in the NQF. The third measure is a hybrid hospital-wide all-cause readmission measure. This measure is proposed to replace the claims-based hospital-wide all-cause unplanned readmission measure starting July 1st of 2023. The hybrid measure is different from the claims-based measure because it also will use electronic clinical data in addition to the claims data. The NQF has also endorsed this measure. Again, if there are any comments or concerns over these three measures, please feel free to contact us. In addition, CMS is seeking comments on three measures that were included in the 2018 Measures Under Consideration list, or MUC list. The MUC list is given to the National Quality Forum every year for stakeholder input on measures that CMS is considering using in future programs. Advent Health is a member of NQF, and they provided comments. They supported the cesarean birth measure, but were concerned about the lack of guidance on what would be included in the hypoglycemia measure. Advent Health was also concerned about the lack of standardization existing in how pressure injuries are staged. AHPA is planning to use these comments that Advent Health has provided. Please let us know if you have any other additional comments or concerns that you would like to share. Now moving on to the Hospital Readmission Reduction Program. This program is a Medicare pay-for-performance program that reduces payments to hospitals with excess readmissions. As expected, the payment adjustment factor continues to remain at 3% to inpatient claims. The fiscal year 2022 performance period will use measures from July 1st, 2017 through June 30th of 2020. While there are not any measures proposed to be added or removed at this time, CMS is seeking to adopt 8 measure removal factors that are currently included in the IQR MVVP program. The measure removal factors are included on the slide and will be discussed in more length later on. CMS also seeks to modify the definition of dual eligible beneficiaries to exclude the number of those that die in the month of discharge in the overall hospital readmission score. Hospitals that care for a large population of dual eligibles are being penalized for having a higher rate of readmissions. This is because dual eligibles tend to be sicker than the rest of the patient population, and this is a way for CMS to risk adjust for these hospitals.
CMS is also proposing some changes to the Hospital Acquired Conditions, or HAC program. So the HAC program is one of the pay-for-performance programs, and it accounts for 1% of that total 6% potential penalty that we were talking about earlier. It works by reducing the total payments for the bottom quartile of hospitals. So in the HAC program, one score is the overall average of each measure. You may remember from last year that each domain is now going to be scored using equal weight, which you can see on the slide. CMS is not proposing to change these measures in any way or the scoring approach for the HAC program this year. CMS is, however, proposing to include the same measure removal factors that we saw adopted last year in OPPS quality programs and some IPPS programs into the HAC program beginning in 2020. So these are the factors that CMS uses to evaluate measures. The newest one is Factor 8. The cost associated with a measure outweighs the benefits of its continued use. Just as a reminder, none of these factors mean that a measure will automatically be removed, but it gives us a peek into the way that CMS is going to evaluate and audit measures. The VBP program is also a pay-for-performance program. However, this one functions a bit differently than its peers. The VBP program is the only quality program where hospitals can earn an incentive payment for good performance. The top performers can gain up to 2% in incentive. Because it's budget neutral, however, it means that the bottom hospitals can also be penalized for up to 2%. VBP pulls measures in from IQR, so it is important for us to pay attention to IQR because that's the preview of what's going to be in VBP. VBP is still composed of these 4 domain weights that are weighted at 25% each: safety, patient and caregiver experience, clinical outcomes, and efficiency and cost reduction. You may notice that clinical outcomes is what used to be called clinical care. Nothing about that domain has actually changed. CMS is just rebranding it and changing the name because that is a bit more accurate of a title. Now, the Promoting Interoperability Program is a mandatory reporting program, so there are no penalties associated, but you have to participate. You may have known this program previously as Meaningful Youth or the EHR Incentive Program, depending on your tenure. CMS is proposing a few changes to this program this year and is including a pretty lengthy request for comment on ways to improve. CMS is proposing to continue the any 90-day reporting period for hospitals to calendar year 2021. We saw this introduced in last year's IPPS rule, and it was going to be applicable for 2019 and 2020. So this is just extending it out to 2021. CMS's proposed changes to the measures and scoring for this program are going to both center around the fairly new opioid-related measures. We saw these introduced last year. So first, CMS is now proposing to make query of the PDMP a voluntary measure that will only earn bonus points. This measure was previously scheduled to become mandatory in 2020. This measure is also proposed to be converted to yes/no instead of being calculated with a numerator and denominator. And secondly, CMS is proposing to totally eliminate the Verify Opioid Treatment Agreement measure. CMS does not believe that this measure is meaningful as it is currently structured, and I just want to underscore how important it is to weigh in when CMS gives us opportunity to comment. Many AHPA hospitals were the ones who advised CMS that this measure, the way that it's structured, is not really useful and it's creating undue burden. And we saw those comments submitted last year, and this year they're taking it out. So if these proposed changes go into effect, the scoring will have to shift a little bit for 2020 in order to make it still total to 100 points. So the points that are originally allocated for these two measures are going to now be absorbed by e-prescribing and provide patients electronic access measures. The total points will still be 100%, and hospitals will have the opportunity to earn 5 PDMP bonus points on top. So in the PI program, there's also a request for information that's included by CMS. CMS is looking for a lot of feedback on ways that it can improve the PI program. We encourage any AHPA members to weigh in with any advice or requests that they have for CMS. We'd be happy to pass them along. The removal of the Verify Opioid Treatment Agreement is just one of those ways that we were able to make a difference last year. Specifically, CMS is requesting that we comment on any potential new substance use disorder measures that we can think of, whether or not they should adopt NQF or CDC opioid measures that are already being used in other programs. They're considering creating a provider efficiency EHR metric, whether we think they should include PI program data on the Hospital Compare website, and anything else that we can think of that would make the PI program better.
And this takes us to the end of the presentation. If you have any questions, please feel free to send them through the chat box or through the phone. No questions? Any comments?
This is just a comment. This is Carlisle, and I just wanted to commend you ladies and offer my appreciation for doing an excellent job of summarizing a very complex rule. And thank you for repeatedly seeking input from AHPA members on the phone on various things that you shared. You know, someone who lives and works in DC and interact with members of the administration, the various agencies do take these comments very seriously and review them, and as Sherry shared, many times they're incorporated into final rules that are proposed. So thank you very much for doing a great job.
Thank you.
You're welcome.
All right, well then, if you have any thoughts or questions regarding these policies, please feel free to contact us, and we will be submitting comments on June 24th. We will also be sharing a draft letter with some of our internal stakeholders as well. Thank you, and have a wonderful afternoon.
Thank you. Same to you.
Thank you.
Thank you.
Thank you.